welcome to this explainer. Today, we're popping the hood on a system we all deal with, but let's be honest, almost nobody actually understands: the United States healthcare reimbursement system. But instead of just crunching dry numbers, we're going to uncover the hidden financial engine that's quietly driving modern patient care. I'm talking about the Advanced Practice Registered Nurse, or APRN. If you've ever found yourself wondering how healthcare actually gets paid for and who is truly generating that value on the front lines, well, you're in exactly the right place.
All right, let's kick things off with a genuinely massive number. In 2019, the United States spent roughly $3.8 trillion on healthcare. Just let that sink in for a second. To put that staggering figure into perspective, it eats up nearly 18% of the entire gross domestic product. That means for every single dollar generated in the entire U.S. economy, about 18 cents is completely swallowed up by the healthcare system. And just for context, that's up from only 5 cents back in 1960.
So, with healthcare spending growing at literally twice the rate of national inflation, it naturally begs the question, right? Where exactly is all this capital flowing? You see, we have an incredibly fragmented system. There's no single, overarching national structure paying the bills, which creates this highly complex, tangled web of payers and providers.
Don't panic about the complex jargon, though. We've got a clear path for today's explainer. First, we'll navigate the trillion-dollar healthcare maze. Then, we'll look at the shift from volume to value. Third, we'll uncover the hidden healthcare heroes. Fourth, we're cracking the coding system. And finally, we'll see who is leading the value revolution. We're taking a macro to micro journey here, going all the way from federal budgets down to a nurse practitioner's daily chart notes.
Part 1. The trillion-dollar healthcare maze. When you actually break down the spending, a pretty massive trend appears. 31% goes straight to hospitals, and another 20% goes to physicians and clinics. So just two sectors consume over half of our nation's entire healthcare budget. Prescription drugs take up another 10%. Understanding these huge chunks of the pie is critical because it perfectly explains why major institutions are so hyper-focused on controlling their costs and optimizing their revenue.
Part 2. From volume to value.
As those institutional expenses just skyrocketed over the last few decades, the system finally realized that rewarding sheer volume was fundamentally broken. Historically, we relied on what's called a fee-for-service model. Basically, do more tests, get paid more money. But today, we're in the middle of a massive transition to value-based care. In this new world, payments are tied directly to quality, safety, and actual patient outcomes. So if a patient gets an infection because a hospital was careless, the hospital is actually penalized financially. On the flip side, they're rewarded for efficiency and keeping people healthy. Now, how does this play out on the ground? It happens through something called diagnosis-related groups, or DRGs. Under this prospective payment system, hospitals are paid a preset fixed amount up front, and it's based entirely on the patient's diagnosis. It doesn't matter if you run 100 extra tests, the hospital still gets that exact same flat rate. So providing efficient, high-quality care without any complications, that's no longer just a nice-to-have, it's an absolute financial necessity for survival. Part 3. The hidden healthcare heroes. Enter the Advanced Practice Registered Nurse, or APRN. Their vital, complex clinical work makes all that efficiency possible, yet they're often totally obscured by the very financial systems they operate within. And, the APRN isn't some sudden modern invention. They've been evolving for well over a century to meet critical healthcare shortages. Nurse anesthetists got their start way back in the late 1800s. Then nurse midwives appeared around 1925, mostly to serve rural areas. The rising complexity of care post-World War II brought us clinical nurse specialists. And finally, in 1965, to combat a massive primary care shortage, the nurse practitioner role was launched. Today, they are the largest and most visible group of advanced practice nurses. But here's the catch. A major hurdle for APRNs, specifically nurse practitioners, is a really controversial practice called incident to billing. This is essentially a financial workaround. What happens is a nurse practitioner delivers the care, but the service is actually billed under a collaborating physician's provider number instead of the NP's own number. The problem here is that this practice makes tracking the real-world contribution of NPs practically invisible to lawmakers, regulators, and data analysts. And honestly, this workaround is incredibly cumbersome. Just to legally bill incident to under Medicare guidelines, there are 7 strict requirements that all have to be met.
The physician has to remain actively involved. They have to physically be in the same building, providing direct supervision, and it can only be for a follow-up visit on an already established plan of care. It's a massive, massive administrative hoop to jump through.
So why jump through these hoops at all? Well, it all comes down to a stark financial contrast. If an NP bills directly under their own provider number, Medicare only reimburses at 85% of the standard physician fee schedule. But if they use incident to billing, the practice gets reimbursed at a full 100%. Because NP salaries are typically lower than physician salaries, this 15% differential heavily incentivizes practices to hide the NP's work under the physician's name just to maximize the clinic's profit. As one of our sources bluntly puts it, the value of their services is often hidden as a result of the frequent practice of billing NP care under physician provider numbers. The system eagerly reaps the clinical benefits of advanced practice nurses, absolutely, but by burying their provider numbers, it keeps their true economic value hidden in the shadows. And without clear data showing just how much care NPs actually provide, it becomes incredibly difficult to convince lawmakers to expand their scope of practice.
Part 4. Cracking the coding system.
To step out of those shadows and prove their worth, APRNs really have to master the language of the system itself. Understanding billing codes is absolutely essential here. Think of it like a giant puzzle. The ICD-10 code explains the why. Why is the patient sitting in the exam room? Is it primary hypertension or maybe a complicated pregnancy? Then the CPT Evaluation and Management or E&M code dictates the what. What level of complexity did the provider actually face? That CPT code is what ultimately dictates how much the provider gets paid for the encounter.
Transforming a patient encounter into an actual paycheck requires a few very specific steps. First up, you perform the medically appropriate history and exam. Second, you assess the complexity of the medical decision-making or calculate the total time spent with the patient. Third, you map that depth of decision-making into a specific 5-digit code, ranging anywhere from straightforward all the way up to high complexity. Overcoding is considered fraudulent, for sure, but undercoding, well, that just means you're leaving hard-earned revenue right on the table.
Part 5. Leading the value revolution.
With a firm grasp on how the money is tracked, billed, and coded, we can clearly see how advanced nurses, particularly doctors of nursing practice, or DNPs, are uniquely positioned to lead the future of healthcare. When you look at how hospitals are actually graded for Medicare reimbursements today under value-based purchasing, the total performance score is split evenly into 4 25% chunks: clinical outcomes, patient safety, community engagement, and efficiency. When you realize that hospitals are financially rewarded or penalized based on reducing infections, preventing falls, and improving patient communication, the clinical leadership of a DNP is literally money in the bank. DNPs directly impact these absolutely crucial financial metrics. They do this by driving systemic quality improvements, standardizing clinical protocols to reduce really costly variations in care, and championing highly collaborative environments. Think about it. When a DNP successfully manages a patient's complex diabetes, preventing a crisis and keeping them out of the ER for 30 days, they aren't just saving a life, they are actively shielding the hospital from massive financial penalties. As this massive $3.8 trillion U.S. healthcare system shifts away from paying for sheer volume and starts aggressively demanding true quality and value, we have to ask a final, vital question. Will we continue to use outdated billing workarounds to hide our most valuable providers in the shadows? Or will we finally give them full visibility, recognize their incredible economic worth, and let them truly lead the future of care? Definitely something to think about next time you step into a clinic. Thanks for joining me for this explainer, and keep learning.